All right, so lower GI bleed recap, right? So sometimes you might get someone order a stool OB in the hospital setting. You just throw that away, right? That is not okay. All right, you don't do fecal occult blood tests. All right, FOBTs or stool OBs or occult blood, which sounds like a witch spell, or I'll be doing occult blood on you, right? So it's also called a guaiac, right? So it's whacked a guaiac. It's not an appropriate thing to do in a hospital setting. It's a thing we do that is no reason, or is useless, right? It doesn't tell you anything about what's going on. On the outpatient side, yeah, for sure. Like a GI office or your primary doctor says, I want you to do a stool OB and see if we see blood. You could have colon cancer, right? There could be, it could be ulcerative colitis or Crohn's disease or something, right? But it's not something that we need to do in a hospital setting, right? There's so many false positives that could be showing up. Oh, they got this. Let's keep you MPO for 2 days, right? And then it's like Friday night. It's like, oh, we're gonna get you on Monday. It's like, what? I can't eat for three days? What's going on? So there's other things we could do. As we mentioned, BU and creatinine ratio has much higher efficacy. We talked about melena and where there's clots or not. Whether we have NG lavage has high efficacy that tells you if you have a lower GI bleed or not, right? We even have those 3-phase CT scans we can do, but again, they have to be active bleeding and probably pretty sick to go to those things in the first place. All right, so lower GI bleeds, we said colon cancers are pretty common. Diverticulosis is common. Crohn's disease, ulcerative colitis, your inflammatory bowel disorders, they can cause it. Hemorrhoids are pretty popular, right? So there's our carcinoma on that side too, and ischemic colitis and mesenteric ischemia we talked about as well as a risk factor for lower GI bleeds, right? And how do you tell the difference? Well, if it's inflammatory, like inflammatory bowel disease, we're going to start seeing a rise in fever, right? A rise in white count. Also, they probably have a history of this. It might be their first time to the hospital, but usually they know they have Crohn's disease or they have ulcerative colitis. It's a chronic disease they have to live with. They have their own medications they're on, steroids sometimes, NSAIDs that they're topical that they take PO. But inflammatory bowel disease can present with fever. What else might present with fever is a diverticulitis, right? Or ischemic colitis, especially if it's causing peritonitis, right? So diverticulosis has fever? No. Diverticulitis has fever, and this is the lower GI bleed list. That's why you're not seeing diverticulitis what on it? Diverticulitis. Diverticulitis has painful left lower quadrant, right? But no GI bleed. Is there like some guy somewhere, like 0.05% of the time, they might have a GI bleed? Yes. But 99% of the time, it's not going to have a GI bleed, right? So Crohn's disease, ulcerative colitis, definitely having an infectious presentation. Ischemic colitis, mesenteric ischemia, they're definitely going to cause a rise in lactate because of hypoperfusion to the gut. Mesenteric ischemia is much more deadly. Both of them have lower GI bleeds, right? Are they going to have melena? Never, right? Because they are usually affecting the left side of the gut. Right, diverticulosis most commonly is in the left lower quadrant, has hematochezia, okay? And is it painful? Diverticulosis is not painful, it does not hurt. It's just painless GI bleeding, right? What's another painless GI bleed? Painless lower GI bleed? Cancer is not painful unless the mass is actually impinging nerves and compressing things. Another one would be like variceal bleeds, right? I have a variceal bleed as well, so a rectal varice. It's not on the list here, but it's also or varices, right? So it's also a no pain, right? No pain for this guy as well. All right, and then hemorrhoids, are they painful? Yes, they're very annoying. Are they like the worst pain ever? No. What's the worst pain ever on that list? What's poop? Pain out of proportion of exam. Which one was it? That was mesenteric ischemia. Was a pain on was extremely painful. Pain out of proportion to exam. All right. Anal fissures usually happen with Crohn's disease. Neoplasias, that's like a mass of some sort. There's other rare ones out there too, but that's going to cause change in stool habits, iron deficiency anemia. It's going to create a prolonged, it's been developing for a while, right? They have lost 20 pounds of weight in the last 3 months. That's probably colon cancer. That's not mesenteric ischemia from AFib, right? That's a more chronic presentation. All right, so bleeding will stop 80-85% of the time in a lower GI bleed. That's good news, right? But upper GI bleed is much more high risk comparatively, right? Are there high risk lower GI bleeds? Yes, there are. Okay, so looking at the history can tell us a lot about what's going on. You have a history of hemorrhoids? Do you have a history of AFib? Do you have a history of family history of colon cancer, right? Have you had even like post-polypectomy bleeding? After they had a colonoscopy, they can bleed for a day or two. All right, and then of course we talked about our paint swatch, right? Black tarry stools with diarrhea or constipation. Which one was it? With diarrhea means we have what kind of bleed? So it's a bleed that's at least more proximal to this. It could be small bowel, right? It could be it, but usually it might be an upper GI bleed. We got to do some more investigation. We got to do a sampling of the GI aspirate. Maybe there's something going on there. Okay, and then what else? So abdominal pain can tell us a lot, whether it's left upper quadrant, right upper quadrant, if it's left lower quadrant, right lower quadrant, if it's periumbilical, all these things can tell us clues about where the bleed might be coming from. Just a note with AAAs, especially if they've had repair of AAAs, with grafts, the grafts can eat through the aorta and eat through the bowel that's next to it and cause a massive GI bleed. That's always going to be a quick bleed because the aorta is feeding that gut. So that's also a significant side effect, right? So you got an aortic with aorta that has a graft in it, right? So you got a graft right there, and then the bowel is next to it, right? So it's going to start hemorrhaging from the graft. Is going to eat through the blood vessel, and also through the bowel wall, and it'll start oozing into that bowel, and then we'll see that on exam. So how do you fix lower GI bleeds? So colonoscopy is rarely the first thing we do. So with upper GI bleeds, we did upper endoscopy first, right? That's a go-to thing because it's usually life-threatening, and that was what we did first, right? So they're going to be buried in blood, feces, or both if they do colonoscopy first, right? You can't prep a bowel nicely for a colonoscopy immediately, whereas an upper GI bleed, you could go in there, you can suck out the blood, you might be able to see what's going on. It has better odds if you do upper endoscopy compared to lower endoscopy. Okay, so what do you do first? Well, CT scans can help us figure out if it's what's going on. They have ischemic colitis. Do they have a colon cancer? Do they have something like a AAA, like we mentioned, that was oozing through or bleeding through, I should say. So doing a GI consult is probably not going to fix this, but they will definitely fix the upper GI bleed. You want them on board, but usually surgery is going to be involved, right? The IR team, interventional radiology, will be involved as well. Right, they are going to be the ones that are going to come in and hopefully save the day, right? So for the win will be embolization, right? They find the source of the bleed and they go in there and they can embolize it for us, right? So we want to make sure we exonerate upper GI bleed source. We want to make sure we say, oh, their GI aspirate is negative and they have no, there's no upper GI bleed here. They had clots coming from the rectum. That is a what kind of bleed? That's a lower GI bleed guaranteed. You have a BN creatinine ratio greater than 30:1, that's upper or lower? That's upper GI bleed guaranteed, right? If you have bilious fluid, you have bile that came from the duodenum, right? Secrete bile there and it makes its way into the gastrum. That is ultimately, that is not a upper GI bleed. That is 100%, it's impossible, right? If there's no blood or bile seen, you don't know. It could be hiding. It could be all growing in a duodenal ulcer, you don't know. All right, but if there's coffee ground emesis, right, or even bright red blood, that's 100% upper GI bleed. You need to do an EGD immediately. That's the next phone call. Phone call after we place that GI, that NG2, that OG tube. All right, so hematochezia, you got unstable hematochezia. What's first? Well, yeah, colonoscopy, but usually upper endoscopy is happening first, right? We do all these things to figure out, is it an upper bleed or a lower bleed? Okay, so sorry, I said they're unstable, so they are not hemodynamically stable, so they are unstable. That's where we do an EGD first, right? EGD is done first if someone's unstable. It's very rare for someone to be hemodynamically unstable with a lower GI bleed. Okay, but if they are stable, we'll go ahead and prep for colonoscopy next morning, get them done, get them prepped, and then we'll go ahead and take a look. Just hopefully we're free of feces and the blood might still be there, but it's easy to wash away with a colonoscope, right? And if they can't, they might need to get a angiography done, right? They go in there with the angiography, they can then see where the bleed's at, and they can hopefully fix it in the IR cath lab slabite, right? Or we might need to have a surgical consult take out the portion of the bowel that might be bleeding or oozing, okay? Again, if you're hemodynamically unstable, it's an EGD first. And if they are bleeding and bleeding and bleeding, you keep checking H&Hs. Will that make them bleed more? Yes, but 48 hours, 72 hours of Q6 H&Hs or Q4 H&Hs is not going to make them bleed more than they usually would. So we transfuse to hemoglobin greater than 7, not any higher. Otherwise, that can worsen what kind of bleeds? worsen our variceal bleeds, whether it be rectal, least common to more common, a gastric or esophageal varice. Okay, so that's the idea behind lower GI bleeds and upper GI bleeds, and what we look at first. We have a lower GI bleed. Colonoscopy is not always first, whereas endoscopy is first with upper GI bleeds. All right, so colonoscopies. So talking about these guys, they need to be done with good prep. So you can see here on the right is poor prep, on the left is excellent prep. So excellent prep, you can see everything. Yes, there might be blood there, but we can easily suction that out, right? If there's poor prep, you can actually miss polyps, and you can miss things that were, oozing or bleeding. So it's been important to have good prep so that we can clearly see what we need to see, right? They're trained to look at target areas, making sure they go all the way to the other side of the bowel to make sure they find the key areas where there might be colon cancer or polyps, key areas where there might be ulcerative colitis, or there might be Crohn's disease, or there might be a mesenteric ischemia, and those key areas that we said might get or sorry, I should say ischemic colitis, right? This is not going to go into the small bowel to be able to see mesenteric ischemia. Okay, so how do you get good prep, right? So good prep is like this elephant pea Gatorade flavor, where they have a clear output. Basically, there should be no chunks. There should not be brown at all. It should be all the way to clear, right? If it's not clear, they might have to take mag citrate, right? Mag citrate will definitely make them clear, right? They're going to see everything that came out in the last 20 years will be there. Okay, but in the meantime, they have to take 4 liters, right? So PEG, right? This is where's my liters at? 4 liters of PEG, or polyethylene glycol. So polyethylene glycol is non-absorbable. It's a sugar, right? Glycol, it's a glucose. It's not absorbable. We don't have any receptors in our GI tract that will take that glucose and put it into our system. So it's going to be, it's osmotically active, so it will pull volume into the gut, and it will definitely, clear you out. Okay, that's the idea behind polyethylene glycol, or PEG, or Go Lightly, right? If it's a low dose, not 4 liters worth, but 1 cup worth, what's that called? 1 cup of Go Lightly is called Miralax, right? Miralax is just polyethylene glycol. That's all it is, right? It's osmotically active. It pulls fluid into the gut and promotes GI motility a little bit as it spreads the bowel walls apart a little bit, right? So Miralax is the smaller form, okay? And then what's the difference between Miralax and Go Lightly and antifreeze? Just one little poly, right? Ethylene glycol is antifreeze, right? But polyethylene glycol, which doesn't get absorbed, for good reasons, is going to be polyethylene glycol is good medicine. Ethylene glycol is not medicine. It's very, very sweet. That's why cats like to drink the antifreeze in the under the hood, under the car, because then they get ulcers. They get stones that develop in their kidneys. They go to renal failure. So that happened to people too. If they overdose the antifreeze, it's very sweet. It's very nice to drink. Don't drink it, please. I'm not advocating to drink antifreeze. But if you get renal stones real quick, and it's going to cause renal failure very quickly. Okay. So anyways, that's antifreeze, and we're not giving antifreeze to these patients. We're giving Go Lightly, and that's going to hopefully get the bowel adequately prepped so we can see a good picture of what we need to intervene upon if it's lower GI bleed or for surveillance sake, right? So that we have colonoscopies at age 45. You should be getting them, right, if they're high risk. I think it's African American gets 45, 50 for white males, but then it's like less, and then they go back and forth. You just gotta look at the current guidelines. But what are the risk factors for it, right? It's done a lot. The risk factors are they can go through, they can poke through the splenic flexure, right? So they could go through there, they could poke through that first turn or second turd really, and they can hit the spleen and cause splenic injury, right? Or they can cause perforation. The most common place is at that area right there, that splenic flexure, right? And then after they snare a polyp, right? So a polyp is snared. It's not banded. It's not clipped. It is snared, right? So they go in there with their little snares, right? They go in there and they snare it, and they snip it off, and they scoop it out, right? And that can then start oozing afterwards, right? They don't care. They just snare it and go on with their day, right? And that can then ooze. It's a very, very small amount of oozing, but they can have post-polypectomy bleeding. Okay, but the most common side effect of a colonoscopy or even endoscopy is sedation related, right? So the sedation from anesthesia has like a 60% complication rate. These ones right here, perforation, splenic injury, are very, very low, but they are there to consider post-op, post-procedure at least. But sedation related is the most common side effect from any kind of procedure, really, but especially colonoscopies since they're done so frequently, and especially with upper GI endoscopies as well. Okay, so you got Miralax over there. What's Miralax? That's just PEG, polyethylene glycol, not antifreeze, right? You got Dulcolax, might be given just to help evacuate the bowels a little bit, but definitely mag citrate is going to be our go-to agent to, at 6 a.m. It's like, oh shoot, they're still not clear. And the GI doctor, you're going to call the GI doctor and say, just give what? Just give mag citrate.
So I heard this gets rid of a stomachache.
Oh, bless your heart, baby. Well, there's no drinking the stuff back out, so you have about 2.5 minutes to go get your phone charger with the longest cord, a gallon of water, and cancel all your plans for tonight and most of tomorrow, because you about to relive every regret, every happy memory, and every fear, and even that Flintstones vitamin you had back in 1991, as it all leaves your body, honey, because you're going to be sitting on that porcelain crown for a while, so I hope your cheeks are nice and ready for it. I mean, it's going to fix your tummy all right, but it's like nailing a nail with a sledgehammer. Does it get the job done? Yes, but is it necessarily pleasant? No, honey. Oh, bless your heart.
All right, so we'll take a break soon, but this is, for researching all of GI, you get to see a lot of endoscopy stuff, right? This is someone who likes to eat hair, right? And the hair then starts forming this there's the stomach right there. It starts forming the shape of the gastrum, right? And this is an example of liver flukes. Right? If you go in fresh waters, you like to swim in fresh water, you can partake in a liver fluke. It will then be absorbed, or not absorbed, but swallowed by you, right? And liver flukes will then make their way past the pyloric sphincter, past the gastrum, and make their way up the sphincter of Oddi, right? And go through into your biliary tree, and they will form eggs in there, and they will then deposit the eggs. And then now it's time for them to birth, and they will then birth, and they will occlude your biliary tree. Right, and obviously make you a little bit jaundiced as you can't get rid of the billy. So they're just live in there. They're just hanging out. That's what they do. Right. So those are liver flukes that will grow in there, and those are fun things to have.
Could have gone forever without knowing.
Well, yeah, I have to share it with you because I didn't want to. So there's another liver fluke up close. All right. So they grow in that biliary tree right under the pancreas, underneath the gallbladder. All right, this one, they're all alive. They like to live at body temperature.
Is that common?
And if you like to swim in fresh water, it's common.
So are these things common?
You get it with with exposure, right? So it's just being exposed to it, you'll get it. I don't know how common it is, but it's definitely there. Okay, it's definitely a thing that you have to consider.
I'm guessing you don't swim in fresh water.
No, no swimming in fresh water. Okay, and then we have I think it's ascariasis is the next one. So these are from eating raw, uncooked salmon. So raw salmon, and these are. So these things they can be extremely long, like 4 feet, 10 feet. All right, they're gonna be it's like weight loss, but it's not the weight loss you intended.
They just pull them out or what?
Yeah, that's what they have to do. It's going to take a lot of extra procedures to get them done. And then what else do we have here? So that's raw salmon. This is one guy just hanging out in the, I think that's also the biliary tree, and they're just going to kind of extract him from there. He's made his way, and they're going to go in there. He's like, come on out. They're going to pull out the guy right there. So definitely symptomatic. It looks like they're in the bowel wall too. That's a less severe case than the other one, right? And then pinworms are also fun. So those are growing all over the place.
That's from pork,
Right.
So for undercooked meat, puts you at risk for a lot of bad stuff. And then just an example of the tracheobozoar, where you're eating hair, so going down the esophagus to go into the stomach and feeling full all the time, right? It's because they're eating their hair. That's what's happening, and it's going to occlude their stomach, and they're going to feel pretty nauseous. That's going to be hard to extract. That's going to be chunks by chunks as well. Yeah, don't swallow too much hair.